That is so awesome. That is so good. I think this is a really good shot.
Hey there and welcome to Behind the Knife. I'm Michael Vu and today we are talking about the arterial line. Now I know this is not the sexiest procedure in the world, but it is important to know how to do one quickly and smoothly for when your patient urgently needs it. And if you ever come across a patient who is massively bleeding to death from somewhere below the chest and you can't stop the bleeding, you can still save their life with something called REBOA, a really simple endovascular balloon device that occludes the aorta. But you can't deploy it unless you know how to get femoral arterial access first. By the way, the REBOA episode is coming out really soon, so be sure to hit that subscribe button if you want to follow along with us and be notified when we push that out. But until then, let's talk about the arterial line, and we'll start with the radial art line. As always, success starts with preparation, so let's hit the supply room and grab the stuff. Here you see I brought a radial A-line kit. Actually, I brought two types to show you. PPE, prep stick, drapes, I like to use a pack of simple towels, suture on a Keith needle so I don't need a needle driver, and local with syringe and needles. Also not pictured is an ultrasound and sterile probe cover. By the way, at my hospital we place A-lines with sterile technique, maximum sterile barrier, and although the literature to support this isn't super strong, it is what I do and what I suggest you do. Still, I do recognize that plenty of people do this procedure with just glove and prep stick, no gown or drapes, and up to you. And of course, you'll need the actual needle, wire, and catheter to get the line in via cell denture technique, similar to my central line video, which you should definitely check out if you haven't seen it. I'll put the link in the top right here. Almost universally these days, you will be placing the arterial line with an arrow, or similar looking integrated dart. This dart is a pretty elegant device that combines these components into one handy tool. Let's have a closer look. Here's the needle. The wire is loaded into the needle and can be fed forwards and backwards through the needle by moving this black tab. Notice that at the moment the wire is about to emerge from the needle, the black tab passes the black line. And this tube is the flash chamber. Once you hit the artery, blood will rise in the tube. Finally, the catheter is already loaded around the needle, ready to advance off the needle and over the wire. By the way, did you notice how stiff that catheter was coming off of the needle? You should always wiggle that catheter off of the needle and then reset it so that it will advance smoothly when the time comes. There are traditional kits that have all these components separated, and I will show you it briefly later in the video. Before you start, you'll need to know which of the patient's arms you actually want to use. Do the modified Allen test to make sure there's adequate blood flow from the ulnar artery alone. Just have the patient clench their fist for 30 seconds until it goes white. Apply pressure over both ulnar and radial arteries, and then have the patient open their hand. Let go of the ulnar artery and watch the white, blanched skin recover its pink color. That should only take 5 to 15 seconds. If you're using ultrasound, have a look at both arteries and consider choosing the bigger one. This is what it looks like under ultrasound, by the way. Dr. Parsons is tracing it up the forearm. The artery will be superficial near the wrist and pulsatile. Now on to positioning. You don't need anything fancier than a towel and some tape for this, so Dr. Parsons is rolling up a towel into a nice bump, somewhat abducting the arm, placing the bump under the wrist to keep it hyperextended, and then taping the hand to the bed in order to maintain this position. Hyperextension brings the artery closer to the surface of the skin and prevents the artery from rolling. Some hospitals actually have these fancy splints which keeps the wrist in extension all by itself. I actually prefer this, and this is what I use, but if you don't have it, the towel works just fine. Well, with all that out of the way, let's get to the good stuff. Open up your supplies and gown and glove up. Prep and drape the patient. Take the lidocaine and just inject a skin wheel's worth of local. While waiting for the local to take effect, go ahead and drape the ultrasound probe. Be sure to flatten out the wrinkles in the probe cover and massage out any air bubbles in the gel. You don't need the ultrasound, and if you choose not to use it, you want to palpate for the artery and attempt the needle stick based on the pulsations alone. But I personally feel that my ultrasound skills greatly increase my chance of success with the first pass of the needle, and there is some research suggesting this is definitely superior to the blind approach. So that's what I show you here. I use the ultrasound to guide the needle down to the artery. You should definitely watch my video on ultrasound-guided access to learn more about using the ultrasound to accurately hit vessels with the needle every time, and I'll put the link right here in the top right corner. Once you think the needle is in the artery, observe the long tube of the dart to see that it is filling with blood. As long as that tube continues to fill, the needle continues to be in the artery lumen. If it stops filling, the needle has either slipped backwards out of the vessel or you have advanced it through the back wall of the artery entirely. Carefully advance the wire all the way by sliding the black tab down. If the black tab slides easily past the black line, this is a good sign. It means the wire is continuing past the needle tip and through the vessel. With the wire fully advanced, carefully advance the catheter off of the needle and over the wire into the vessel. Withdraw the rest of the dart, put your thumb over the hole so you're not spewing blood everywhere, and ask the nurse to hand you the A-line pressure tubing. This dart comes with that blue tab that's supposed to help you sew it in, but I just wrap the suture around the hub. So as you can see, the arterial line is pretty darn simple in principle, but we all have line placements where that damn wire just won't advance. So let's talk some troubleshooting tactics. Here I am trying for the art line again. This time you see blood enter the flash chamber and it starts to rise up the tubing. But because I had too much coffee this time, I accidentally nudged the dart too far forwards and now it's back-walled. So the blood stops rising in the tubing. And when I go to advance the wire, I find that the tab won't advance past that line because I'm no longer in the artery. So anytime you've got blood in the tubing but it stopped rising and the wire won't advance further, you have to strongly consider a back-walled artery as the explanation. The troubleshooting tactic here is to very slowly withdraw the needle, millimeter by millimeter. As you withdraw the needle, watch the clear tube. If blood begins to rise in the tube once more, then stop withdrawing the needle and attempt to pass the wire once again. By the way, if you find that you're backwalling the artery frequently, consider entering with the needle at a shallower angle next time. That'll give the needle more leeway inside the vessel before it ends up backwalling. If you make too many attempts on that artery, it will constrict and become near impossible for you to cannulate, so you should just switch to the other hand. Besides the darts, they do have traditional Seldinger kits, which you can use to establish arterial access. I use this very uncommonly, but I do have friends who prefer this method, especially when the artery is very small. The reason is because the dart's long, floppy tube can be cumbersome, and they prefer to wield a small needle alone for precision cannulation. So I briefly gloss over it here. I mean, the idea is basically the same. Alright, next let's briefly talk about the femoral arterial line. The steps are pretty much the same, so if you can do the radial A-line, you can do the femoral A-line. There's just a few extra considerations you need to keep in mind. First, you need a femoral length arterial catheter. You can't use the same type of line that you would put in the wrist. Second, you'll primarily be doing this in crashing patients. It's going to be a dirty line in such conditions, since you won't have time to prep and drape. If an ultrasound is very nearby, I will still use it, but of course I don't waste time with the probe cover. Here's what it looks like under ultrasound. If an ultrasound is not available, you'll have to go in blind using landmarks, and you shouldn't expect to feel a femoral pulse in a crashing patient. So remember, the artery is lateral to the vein. I will find the pubic tubercle, that bony prominence on the lateral side of the pubis, and measure 3 finger breadths laterally. If you miss and you hit the vein instead, no big deal. You can use that stick to put in your crash central venous line instead. And when you're done with that, try for the arterial line again. This time, aim lateral to your new femoral central line. Again, if you want to learn about central lines, don't forget to check out our other video on it. One last thing I wanted to talk about, hooking up the arterial line. I must admit I didn't know how to do this throughout all of medical school and even intern year because the nurses always did it for me. Very embarrassing. To hook up the arterial line, you will need the transducer tubing, a saline bag, and a pressure bag. Make sure you've got the right caps on the tubing and make sure that the caps are tight. Spike the saline bag with the end of the tubing and then empty the saline bag of as much air as possible. And then place it under 300 millimeters of mercury of pressure in the pressure bag and open the lines up to flush the lines completely. Some lines have pigtails that you pull and other lines have tabs that you press in order to open the tubing to flush it. With the line flushed, you can hook it up to the arterial catheter, but you still need to zero it. What we mean by zero is we want the line to subtract out the atmospheric pressure, which is dependent on how high the transducer is. So place the transducer portion of the tubing at the patient's heart level, which some people call the phlebistostatic axis. You can attach the transducer to a plate that hooks onto a pole, which you need to raise or lower to match the heart level. But a common nurse trick is to affix the transducer to a rolled towel that is kept at the patient's side, which will follow the patient if the bed is raised or lowered. And don't forget to plug in the transducer's electronic cable into the monitor. Now to zero the line, make sure the transducer's stopcock is turned off toward the patient, and then pull the cap off of the transducer. Now the transducer is directly interfacing with the atmospheric air. Press the 0 button on the monitor to zero the line, then put the cap back on and turn the stopcock so it is once again on toward the patient. Well, that's it for this week's episode. I know I have a lot more to work on for you guys. You guys have left a ton of comments about follow-up videos that you want me to make. And don't forget, Riboa, the episode is coming out soon. And if you want to be notified when that or other episodes come out, be sure to hit that subscribe button. Until next time, dominate the day.